Good day, I am Dr.K Gireesh, physician, neurophysician and neurosurgeon. This is the RNA series 67. RNA is nothing but random questions in neurology and neurosurgery with the answers by Dr. K Gireesh. This is to benefit the practitioners of neuroscience and the medical field for a lifelong learning and also for public awareness. In this series, the question that I am addressing is, what are the neurological or the neurosurgical manifestations of acquired immunodeficiency syndrome, AIDS? Now, the neurological manifestations of acquired immunodeficiency syndrome include a direct effect of HIV on the nervous system. That will be HIV-associated neurocognitive disorders. It's called HA HIV encephalopathy. The second one is opportunistic CNS infections like cerebral toxoplasmosis, cryptococcal meningitis, TB meningitis, progressive multifocal leukoencephalopathy, cytomegalovirus infections. The third is HIV-related neoplasms like the primary CNS lymphoma. Then cerebrovascular manifestations, vasculitis and coagulopathy. The fifth one will be the spinal cord manifestations like vacuolar myelopathy, infective myelitis. And the sixth one with the peripheral nervous system manifestations, distal symmetric polyneuropathy. And the seventh one will be the muscle manifestations like HIV myopathy. So you find the brain can get affected, the spinal cord can get affected, peripheral nervous system can get affected, and also the muscles. Each one of these very briefly we can see. Let's see the direct effect of HIV on the nervous system, and that is the HIV-associated neurocognitive disorders. Like the spectrum includes asymptomatic neurocognitive impairment, mild neurocognitive disorders, HIV-associated dementia, and the clinical features are memory impairment, poor concentration, psychomotor slowing, personality changes, depression, then apathy, executive dysfunction, dementia in advanced diseases. Dementia is nothing but the global loss of intellectual functions. And the pathogenesis is HIV infects the macrophages and the microglia. Neuroinflammation and cytokine injury can occur. Neuronal dysfunction without the direct neural infection too can occur. HIV encephalopathy is the other one. The features are cognitive decline, behavioral changes, gait disturbance, motor slowing, diffuse cerebral dysfunction, and the MRI shows diffuse white matter changes and cerebral atrophy. So these are the direct effect of HIV on the nervous system. The second one is the opportunistic CNS infections. They include the cerebral toxoplasmosis. It is caused by the Toxoplasmosis gondii, and the most common focal brain lesion in the AIDS is headache, fever, seizures, focal neurological deficits, altered sensorium. You get in MRI or CT multiple ring-like lesions, and the basal ganglia will be the preference, surrounding edema will be there, and the neurosurgical relevance is if the diagnosis uncertainty may require a stereotactic biopsy, but may not be required. Raised IZP occasionally requires intervention. The second one is cryptococcal meningitis. That is the opportunistic infection. They are caused by cryptococcosis. Features are headache, fever, neck stiffness, visual disturbance, raised ICP, and the neurosurgical relevance is that repeated LP. Sometimes CSF diversion procedures will have to be done, especially when you have refractory raised ICP or hydrocephalus. A VP shunt will have to be done. Third is the tuberculous meningitis and tuberculoma. Very important in India. It's caused by tuberculosis. Features of fever, headache, cranial neuropathies, hydrocephalus, and focal deficits. And if there is a hydrocephalus, that has got to be treated. And if there is a tuberculoma, a neurosurgical manifestation might be required, otherwise not. Progressive multifocal leukoencephalopathy, which is caused by a reactivation of the JZ virus. Features are progressive focal deficit, hemiparesis, aphasia, visual field defects, cognitive decline, and MRI shows multifocal non-enhancing white matter lesions, usually managed medically, biopsy very rarely needed. And fifth is the cytomegalovirus disease. That's called the opportunistic infection caused by the cytomegalovirus infection. Manifestations are encephalitis, ventriculoencephalitis, radiculomyelitis. Features are confusion, cranial nerve involvement, cardiac Weiner syndrome, and a weakness. So that is the opportunistic CNS infections. The third is HIV-related neoplasms that can occur as a neurological manifestation of AIDS, which is the primary CNS lymphoma, PZNSL. Diffuse large B-cell lymphoma, usually associated with Epstein-Barr virus. Again, focal deficits, seizures, raised ICP, cognitive decline. An imaging shows a homogeneously enhancing lesion or a deep periventricular occasion, and sometimes we might have to do a stereotactic biopsy for confirmation. And cerebrovascular manifestations can be either vasculitis or coagulopathy. And AIDS may predispose to stroke due to vasculitis, coagulopathy, opportunistic infection related vasculopathy or cardioembolism. Manifestations are ischemic stroke, hemorrhage or venous thrombosis. Clinical sudden focal deficit, hemiplegia and aphasia can occur. Spinal cord manifestations is vacuolar myelopathy, infective myelitis. These two can occur. Vacuolar myelopathy, common in the spinal cord disorders in advanced age. The posterior and lateral column degeneration occurs. You get a progressive spastic paraparesis, sensory ataxia, and urinary symptoms. MRI often normal or cord atrophy will be there. Then an acute transverse myelitis can occur. May come from a CMV, tuberculosis, HSV, or what you can say the drug related. Features are weakness, sensory loss, finger dysfunction. And you can also get peripheral nervous system manifestation as the sixth one. Distal symmetric polyneuropathy, burning feet, pain, tingling, sensory loss. And the causes are HIV itself or as a result of the treatment, antiretroviral toxicity. Sometimes you get an inflammatory demyelinating neuropathy like a Guillain-Barré syndrome or a chronic infective demyelinating polyneuropathy, ascending weakness, areflexia, and mononeuropathies can also occur like the facial palsy or multiple mononeuropathies or even a radiculopathy. And seventh one is a muscle manifestation like HIV-induced myopathy, a proximal weakness, elevated creatine kinase and myalgia. Causes are HIV, opportunistic infection and drug toxicity. So the neurological manifestations are a direct effect of HIV on the nervous system like HIV-associated neurocognitive disorders, HAND hand, and HIV encephalopathy. The second one is an opportunistic CNS infection which can include cerebral toxoplasmosis, cryptococcal meningitis, TB meningitis, progressive multifocal leukoencephalopathy, cytomegalovirus infections. Third one is HIV-related neoplasms like the primary CNS lymphoma, which is rare. Cerebral vascular manifestations are the four, which can either be a vasculitis or a coagulopathy. And 5 is a spinal cord manifestation like vacuolar myelopathy or infective myelitis and transverse myelitis, an acute one. And 6th one is a peripheral nervous system manifestation like a distal symmetric polyneuropathy. And 7th is a muscle manifestation, HIV myopathy. These are indeed the neurological manifestations of acquired immunodeficiency syndrome. The incidence of course varies, and if you look at it, you find as a study, what you can say, done by Levy et al. And as well as the Wadia et al. And if you look at Levy et al., you find the incidence in percentage, which he has done, what you can say, for the large series, is you find the subacute encephalitis will be around 17%, herpes simplex encephalitis will be around 2.8%, then the others like the toxoplasmosis around 13% in the last series of cases which has been studied, Candida albicans 1.9, coccidiomycosis 0.31%, and primary CNS lymphoma is around 4.7%. So these are a large series of studies which Levy et al. Has carried out and published in the Journal of Neurosurgery in 1985. And in India, this one of the largest series of the studies that have been done has been documented by R.S. Wadia in the Journal of Association of Physicians in 2001, which is in fact 1,527 HIV positive subjects, and they did find that 457 patients had neurological manifestations. The prevalence was around 20.24%, and involvement of all levels of neuroaxis were in fact documented. The commonest of the manifestation were the neuropathies, including herpes zoster in 28%, meningitis in 17%, and mass lesions around 16%. Cryptococcal meningitis was clearly commoner than the tuberculous meningitis, 67% versus the 18% of all cases of meningitis. Among the mass lesions, 14 out of 24 single lesions and 27 out of 38 had multiple lesions which were responding to antitoxoplasma treatment. So, in the this is the absence of a biopsy, they did empirical treatment was in fact given. So, to their knowledge, the author's knowledge, that is R.S. Wardia and team, this publication has been one of the largest series of neurological manifestations of HIV disease documented in the Indian literature. So, the key message: the neurological complications in AIDS arise from the direct HIV injury, opportunistic infections, tumors, vascular disease, and treatment-related complications. Many conditions are potentially treatable, and neurosurgical intervention is often crucial in hypercephalus, focal lesions, mass effect, and diagnostic dilemmas. And we have further references like the Adam and Victor's Principle of Neurology, Greenberg's Handbook of Neurosurgery, and also the HIV neural complications guidance by the WHO and also by the CDC. That's it. Thank you. Thank you very much.